this government is using radios to do all that manually, this allowed them to have instant situational awareness, especially for, say, a mass casualty incident. They were able to much better sense how many cases they need to send and how many traumas to send to hospital A versus hospital B. And lastly, I think there's a real opportunity when you're able to send rich clinical data beyond just a radio report to expand care coordination and to improve medical outcomes for medical emergencies where early activation of complex teams are really important. These are for heart attacks, for strokes, and for trauma. So I just want to leave you with this one tidbit, which is that as I learned through my training program about this, that radios have been the standard of communication from ambulance to hospital since World War I. That was the first time that radios were put into ambulances, and this is still what we're using across the country. I think it's time that we change that. I want to thank a few people, especially the people at South Shore Hospital who helped make this happen, the folks at Twiage, my hospital, the Brigham Women's Center, and also the Massachusetts Medical Society who helped fund a lot of this work. Thank you so much. I'm happy to take your questions.
Great, so you have a few minutes for questions, if you don't mind stepping up to the microphone.
Hello, wonderful presentation, thank you. Very exciting, by the way. Daniel Cook, I'm with the Indian Health Service. I have an unusual question. I wanted to get your insights about what you learned when training up the staff, both the in-hospital staff and the mobile staff. What was your take on tech literacy for the differences between the tech literacy between both sides?
So it's a great question. Thank you so much. I think the tech literacy is a little bit different, as you kind of alluded to, between the hospital side and the paramedic side. In Boston, I'd say most people have a smartphone. Some people still have a flip phone, but the app itself, we didn't find people had trouble with. What people who weren't familiar with smartphones might have had trouble with was, after I exit out the app, how do I open it up again? Like you click the icon over here. How do you unlock the app? I accidentally clicked the button on the side, now it's locked, I need to get back in. So yes, there were some folks who were not familiar with smartphones and who needed a little bit of that, but that was really basic. Our app actually only has 3 screens. That's it. There's no sub-menus, there's no tiered. We automate as much as possible. We have everything in big buttons. If you want to undo anything, you just tap again. It's trying to be like as simple and as intuitive as possible. Using that, it was very simple because we kind of have a very limited set of features. And then on the hospital side, we actually found that incredibly simple because we just said, it's on your dashboard, it comes up all the time, it gives you an alert, we flash whenever it comes up, and all your data is there. They didn't have any trouble. And especially, the nurses loved it when we said you don't have to pick up the radio anymore. That's like, when it calls, of course, ring, but we're gonna cut that away, and for when you get a triage case, just tell the doctor that you want them to take a look at triage. You don't have to write any of that. That was super simple.
Thank you very much.
Of course, thanks.
Thank you, too, for enlightening us. Excellent presentation. I'm Roseanne Fairchild, Health Services Researcher from Indiana State University. And I'm just curious, have you analyzed your data yet based on your pilot? And if so, how are the data showing that you improved medical outcomes? And what was your study design?
Yeah, so I am, as a fellow former health services researcher, I think we are absolutely looking at outcomes. It takes longer to do a chart review because we have to then follow those patients and see what happened. So I think it'll take a little while longer to figure out. Currently, we're doing a case series. So we haven't chosen to have control patients where we're going to do a survival analysis. The other challenge, I think, with our pilot is that with 121 patients and just only a handful of them being the really acute ones, we're not going to really be powered to see outcomes. The next step actually is doing wide deployment, which means that we're going to cover every ambulance in this hospital's network for those private ambulance companies, and we're ramping that up now. The idea is we need to have a certain number of cases, probably up to about 1,000 cases, before we say, oh yes, we statistically significant saved a life. Even though I think we all hope that would happen.
Have you thought about matched cohort analysis, where you would go back prior to using Twiage and match cases on gender, age, and,
Yeah,
and such,
yeah.
and diagnosis? Okay.
The hospital itself collects excellent data on this, and in the initial part, before we even analyze outcomes, what we'll analyze are time metric outcomes. So door to doctor time, door to room time. Those are our metrics that we're already completing and watching and working with the hospital to collect, and I think we'll be able to show an outcome there first. We already are seeing it, and then with a larger set, we'll show outcomes. Thank you.
Thank
Time
you.
for one more question. Thanks.
Hi, Kelly Mills from Indiana as well. I'm an ER nurse, and my question is in regards to the HIPAA compliancy that you referenced and the photos, that patient consent, how that is accomplished.
Yes. So HIPAA compliance is incredibly important to us, which means that the entire system is designed with that security in mind. It means that nothing is saved locally. So for example, if you use the Twiage app to take a picture, let's say this happened to be a movie star, there's no way for the paramedic to go back and decide to put it on Facebook. It's impossible. If we lose the phone, everything is double encrypted, which means that you can try to crack our phone, but you have to crack the server as well to get that. And then in terms of, I think you asked about kind of security of the consent of taking photos. Our general policy was that since this is a little bit of a gray area for the hospital policy, we said if the patient said, you know, I prefer you not take a photo, then we would say no problem. Generally it was an issue because people weren't taking pictures of faces. They were taking pictures of like limb injuries. And so most people didn't feel that that was a problem.
So are they not using their own personal phones?
Currently we're using devices for the ambulance.
Okay, well, thank you very